Alright, this is Pack 365, myself Srija. So today in this session you are going to learn about the continuation of ICD 10 CM coding guidelines for pregnancy, childbirth and puerperium. So coming to the C guideline, pre-existing conditions versus conditions due to pregnancy. So when coding pregnancy cases in ICD 10 CM chapter 15, we must know when the mother's condition started, that is pre-existing condition. So a condition the mother already had before she became pregnant. So what will be the examples like diabetes, hypertension, epilepsy, thyroid disorders. So these conditions, they can affect the pregnancy. So special codes are used to show it is pre-existing. So what are the conditions caused by the pregnancy? So these are the problems that develop because of pregnancy. For example, gestational diabetes, pregnancy-induced hypertension, hyperemesis gravidarum, that is severe vomiting due to pregnancy. So these get different chapter 15 codes because they are direct results of the pregnancy. So why is this important? Because chapter 15 codes are very specific. To code correctly, you must decide, did the condition exist before pregnancy or did it start because of the pregnancy? So this information helps the coders to assign the right category of O codes, that is O002 O9A series. So some categories, they do not separate pre-existing versus pregnancy related. So in such cases, how do you assign the code? So same code can be used for both if the category does not specifically distinguish. And also, if a condition starts after delivery, that is postpartum period, during the delivery encounter, you can still use the appropriate chapter 15 codes. So codes for the puerperium. Okay, so this is about the C guideline. So next coming to D guideline, pre-existing hypertension in pregnancy. So category O10. So this category is used when the mother had hypertension before pregnancy and it now affects pregnancy, childbirth or the postpartum period. So category O10, they also cover the cases where hypertension has caused other long-term problems such as hypertensive heart disease, hypertensive chronic kidney disease. So when coding, you must check, did she have high BP before pregnancy? If yes, you have to assign O10 codes. So does she have related heart or kidney problems? So what you have to do, you have to use the correct combination code inside O10. So this is about the guideline. So next is fetal conditions affecting the management of the mother. Sometimes the baby, that is fetus, has a problem and because of that problem, the doctor needs to do something extra for the mother. So in such cases, we have to use special IC10 codes from O35 and O36 category. So codes from categories O35 and O36. So what is category O35? It is used for maternal care for known or suspected fetal abnormality and damage. So this means there is a fetal abnormality which is real or suspected. And because of that, the mother needs extra checkups, extra tests, and extra treatment. For example, baby suspected to have Down syndrome, or baby has a heart defect, or abnormal ultrasound findings. Then you have to need extra maternal care. So what is category O36? O36 is for maternal care for other fetal problems. So this is used when the fetus has a problem that is not an abnormality but still affects the maternal management. For example, like decreased fetal movements, fetal growth restriction, RH incompatibility, poor fetal heart rate monitoring, and also fetal anemia. Now, what is the important rule for coding category O35 and O36? You have to assign this O35 or O36 only if the fetal condition actually changes the mother's care. So this means that fetal problem must require extra ultrasound, extra monitoring, special maternal observation, diagnostic testing, hospital admission, possible early delivery, and possible termination decision. So if the fetal problem is noted but it does not change the mother's management, you should not assign O35 or O36 codes. So example, if an ultrasound shows minor benign fetal cyst, so doctor says no action needed. That is, you have to not assign the O35 code. So fetal suspected of congenital heart defect or extra echo done, you have to assign the code O35. So next is in utero surgery or fetal surgery. So sometimes surgery is performed on the fetus while still inside the uterus. So which code you have to use under this condition? O35 codes, because the fetal abnormality or problem is the reason for the surgery. For example, fetal spina bifida repair in utero. So you have to use O35 code. So fetal bladder obstruction relief surgically. You have to use O35 code. So what is the key point? The diagnosis code identifies the fetal problem even though it is the mother's medical record. So why do we code fetal problems under the mother's record? So because the fetus does not have a separate medical record yet. So any condition of the fetus that changes the mother's care is recorded on the mother's chart. So this is about the O35 and O36 category codes. So next is HIV infection in pregnancy, childbirth and puerperium. So when a pregnant woman has HIV, coding must show both that she is pregnant and HIV is affecting the pregnancy. So that's why ICD-10 uses O98.7 category codes which shows the HIV complicating pregnancy. So what is the first guideline? When HIV related illness is the reason for the admission. So if the mother is admitted because of an HIV related illness such as HIV related HIV related fever, HIV wasting syndrome, pneumonia caused by HIV or any HIV complications. So the principal diagnosis should be from O98.7 category, which means HIV complicating pregnancy, childbirth or the postpartum period. So then you should add the codes for the specific HIV related condition, for example like pneumonia, infection, etc. So when we take an example like a pregnant woman is admitted for HIV related pneumonia. So what will be the principal diagnosis? O98.713, which describes HIV complicating pregnancy, and the additional code is J18.9 for pneumonia unspecified. So the second guideline is about asymptomatic HIV with no symptoms. So if a pregnant woman has HIV but there are no symptoms and the admission is not for an HIV related illness, so you have to assign O98.7 category code which describes HIV complicating pregnancy and Z21 for asymptomatic HIV infection status. So why Z21? Because Z21 shows the patient is HIV positive but not sick from HIV. So you have to always use O98.7 to show HIV is affecting the pregnancy even if it is asymptomatic, that is there are no symptoms at all. So you have to add another code for the HIV related illness only when one is present, and asymptomatic HIV is coded with Z21 plus O98.7 category code. So this is about F guideline. So G guideline is the diabetes mellitus in pregnancy. So diabetes, it is a major complication during pregnancy because it can affect mother as well as baby. So ICD-10 codes uses O24 codes to show that the pregnant woman is diabetic. So types of diabetes in pregnancy, they fall under O24. So pre-existing type 1 diabetes, so woman had type 1 diabetes before pregnancy. So O24.0 category code is assigned. Pre-existing type 2 diabetes, O24.1. Gestational diabetes, nothing but the diabetes that starts during the pregnancy. You have to assign the code O24.4. And diabetes due to medications or conditions, like secondary diabetes, you have to assign the code O24.8. So why do we code this separately in pregnancy? Because both HIV and diabetes, they can seriously affect the pregnancy. So ICD-10 requires special pregnancy codes, that is O codes, additional codes for underlying conditions, and coding is based upon whether the condition existed before pregnancy or started during the pregnancy. So next guideline is long-term use of insulin and hypoglycemics. So some pregnant women take insulin, that is oral hypoglycemic drugs or medicines that lower the blood sugar. So if a woman uses these medications long term, another code must be added to show this. Like these codes come from Z79 category. Okay. So Z79.4 is for long term or current use of insulin. And Z79.84 is assigned for long term or current use of oral hypoglycemic drugs. So these are the additional codes which are used along with the pregnancy diabetes codes. So why do we add these codes? Because they show how the diabetes is being controlled through diet, insulin or medication which affects the pregnancy management. So next is gestational, that is pregnancy induced diabetes. So what is gestational diabetes? Gestational diabetes is the diabetes that starts during the pregnancy, usually during the second trimester or the third trimester. So it happens in the women who were not diabetic before the pregnancy. So why is this important? Because gestational diabetes, they can cause the complications such as large baby, macrosomia, high blood pressure, which is there is a need for C-section, and risk of newborn low blood sugar. So it also increases the mother's chance of developing type 2 diabetes later in the life. So now how would you code the gestational diabetes? So use only codes from O24.4 category. So these codes represent the gestational diabetes mellitus. So you cannot mix O24.4 codes with any other diabetes codes from the O24 category. So types of gestational diabetes codes. So the subcategory O24.4, they include O24.410, which describes diet controlled gestational diabetes. That is, woman manages the blood sugar with diet. There is no medication. And there is another code O24.414, which describes insulin controlled the gestational diabetes. So woman uses insulin during the pregnancy. And there is O24.419, which is controlled by the oral hypoglycemic drugs. So woman uses tablets like metformin or metformin. So these codes help the describe how the diabetes is being managed, which is clinically important. So what is the coding rule reminder here? Gestational diabetes always uses O24.4 category codes. You should not never combine with any other O24 codes. So you have to always add medication codes if they are needed. Like if insulin or oral drugs are used long term, you have to add an additional code like Z79.4 for long term insulin and Z79.84 for long term oral hypoglycemics. So this is how you code the gestational diabetes. So what are the coding rules for gestational diabetes? So gestational diabetes, they can be controlled in different ways. The coding must show how it is controlled. So if it is treated with both diet and insulin, you have to use only the insulin control code because insulin control is stronger and more specific. So if it is treated with diet and oral hypoglycemic tablets, so you have to use only the oral control code because medication control overrides the diet control. So what are the important notes about the additional codes like Z79 category? These Z codes, they describe long-term use of diabetes medications. Like you should not use Z79.4 or Z79.84 or Z79.85 with gestational diabetes codes. Why? What is the reason? Because O24.4 codes already tell us how the gestational diabetes is being controlled by diet, insulin or oral drugs. So adding Z79 codes, they would be the double coding. Okay. So the Z79 codes are only used for the long-term use of insulin, long-term use of oral hypoglycemic drugs and long-term use of injectable non-insulin diabetes drugs. So these are used only for the pre-existing diabetes but not the gestational diabetes. So now, what is the abnormal glucose tolerance in the pregnancy? Not all high blood sugar in pregnancy is a gestational diabetes. So if the patient has abnormal glucose tolerance, that is mild increase in the blood sugar, but they are not confirmed by the gestational diabetes. So you have to use O99.81, which is the abnormal glucose complicating pregnancy. So this is used when blood sugar is higher than normal, but criteria for gestational diabetes, these are not fully met. So all doctors, they document the glucose intolerance in the pregnancy. So O99.81 code must be assigned for abnormal glucose complicating the pregnancy. So next is J. Sepsis and septic shock complicating abortion, pregnancy, childbirth and the puerperium. Sepsis is severe body infection. Septic shock is dangerously low blood pressure from sepsis. So ICD-10 requires special rules when sepsis happens during pregnancy or postpartum. So what are the coding guidelines for sepsis in the pregnancy? The step 1, you have to assign chapter 15 codes. So you have to use an O code to show the sepsis happened during pregnancy, labor, delivery or postpartum. So what are the examples? O85 is for sepsis following delivery. O75.1 is for shock during labor. And O03.87 is for sepsis following incomplete spontaneous abortion. So exact code depends upon the timing and situation. So step 2 is you have to add a code for the specific infection. Like examples like A41.9 is assigned for sepsis or unspecified organism. B95 to B96 is for bacterial cause, that is Streptococcus and Staphylococcus, etc. So this tells us what the infection caused the sepsis. So now what is the severe sepsis route? Like how do you code for a severe sepsis? So if the patient develops severe sepsis, that is sepsis plus organ failure, then you have to assign the code R65.2 for severe sepsis and codes for organ dysfunction, for example like acute kidney failure or respiratory failure. So why? Because this indicates how serious the condition is. So for gestational diabetes, you should never use the Z79 codes and you have to use only one code depending upon how it is controlled. Insulation or medication always overrides the diet. So for sepsis, pregnancy always gets an O code first. So it always code the infection organism if it is known. So severe sepsis needs extra codes. So next is puerperal sepsis. So what is puerperal sepsis? Means a sepsis that is a severe body infection that occurs after the childbirth. So this infection, they usually happens in the mother's uterus or reproductive tract after the delivery. So what are the key coding guidelines? So you have to use code O85 for puerperal sepsis. So this code is always the main code when documenting sepsis happening during the postpartum period, that is after the delivery. The second rule is you have to also assign a secondary code to identify the organism. For example, if the infection is due to E. coli, you have to use a code for B95 to B96. So these codes, they show which bacteria cause the sepsis. So this helps to show what germ is responsible. So what is the third rule? You should not use the codes from A40, that is streptococcal sepsis, or A41, other sepsis. Why? Because the obstetric code O85 already represents the sepsis during the postpartum period. So coding both would be double coding. Okay. So the next rule is if severe sepsis is present, you have to add code R65.2. So if the mother has organ failure, very severe infection, then you have to add a code from R65.2 category to show the seriousness of the condition. So for example, O85 plus R65.21, severe sepsis with the septic shock. So do not use O85 if sepsis happened due to an obstetric procedure. So sepsis after a C-section or infection and sepsis after the episiotomy repair. So in this case, you have to use the code for post-procedural sepsis. That is section IC1D 5B. So next guidelines is about alcohol, tobacco, and drug use during pregnancy, childbirth, and the puerperium. So this category deals with the mother using alcohol, tobacco, or drugs at any time during the pregnancy, delivery, and postpartum period up to 6 weeks after the delivery. So what is the first rule? Alcohol use during the pregnancy, childbirth, or puerperium. So you have to use code from O99.31 subcategory. So this code is used whenever a pregnant or postpartum patient uses alcohol, even if there are no symptoms. So why do we code it? Because alcohol use during the pregnancy, they can cause us the miscarriage, preterm birth, low birth weight, and also the fetal alcohol syndrome. So medical records, they must reflect the alcohol use affected the pregnancy care. So why separate codes for pregnancy related sepsis? Because sepsis in the pregnancy or postpartum is more dangerous and management differs from general sepsis. So why do we code the organism separately? Because the specific bacteria, they help to guide the treatment, antibiotic choice, and severity assessment. Why code alcohol use even without symptoms? Because it influences the risk level of pregnancy, counseling, monitoring, and also baby's future health. So here are the guidelines related to the substance used during pregnancy, childbirth, and puerperium. So when coding medical records for pregnant women, we must always record if they used alcohol, tobacco, or drugs during the pregnancy, because this can affect both the mother and the baby. So the ICD-10 system, they requires two types of codes. So a code showing the problem during the pregnancy, which involves O99 category, and a second code showing the type of the substance which uses F10 to F9 categories. So let's break down. What is the first one? Alcohol used during the pregnancy. So if a pregnant patient uses alcohol, we use O99.31 category code, which describes alcohol use complicating the pregnancy, and a second code from F10 category, which describes alcohol related disorders, must also be added to show the exact type of alcohol problem. For example, dependence, abuse, and intoxication. Why? Because alcohol can cause complications such as fetal alcohol syndrome, miscarriage, or low birth weight. And the second guideline is tobacco use during pregnancy, childbirth, and a puerperium. So puerperium is nothing but period after the childbirth, usually 6 weeks. So you have to use O99.33 category code when the mother smokes or uses any tobacco product during pregnancy or postpartum. You have to always add a secondary code from the category F17 to show the type of nicotine dependence, like for example cigarettes, chewing tobacco, or e-cigarettes. So tobacco uses, they increases the risk of premature birth, low birth weight, placenta previa, and sudden infant death syndrome. So next guideline is about drug use during pregnancy, childbirth, and puerperium. So you have to use O99.32 category code when a pregnant woman uses drugs during the pregnancy or postpartum. So this includes the illegal drugs, for example, heroin and cocaine, misuse of the prescription drugs, for example, opioids and sedatives, and also inappropriate use of medications. So you have to add a secondary code from F11 to F16 or F18 to F19 depending upon the type of the drug. So F11 is for opioids, F12 is for cannabis, F14 is for cocaine, and F19 is for multiple drugs, etc. So drug use, they can cause the withdrawal symptoms in the newborns, birth defects, and stillbirth, and also pregnancy complications. So O99 codes, they show substance uses during the pregnancy, and F codes show what substance was used. So both the codes are needed because they describe the effect on the pregnancy and the specific substance involved. So this is about the drug use, and the next guideline is about poisoning, toxic effects, adverse effects, and underdosing in a pregnant patient. So when a pregnant woman has a problem because of a medicine, chemical toxin, or drug, so we must use specific ICD-10 rules to show this event complicates the pregnancy. and what type of substance related problem happened. So first code is 09A.2, which describes pregnancy complicated by injury, poisoning or other external causes. So you must always start with a code from 090A.2. So this tells that the woman's pregnancy was affected by poisoning, toxic effect of a substance, adverse effect of a medication, underdosing or any other similar external cause. So what is the second code? The actual substance problem code. So after 09A.2, you have to add the code that explains what went wrong, whether it is a poisoning or toxic effect or adverse effect or underdosing. Okay. So second code shows the exact substance and what type of problem happened. So third code is about the condition caused by the poisoning or effect. So sometimes you also need another code to show what condition resulted. For example, like respiratory failure, hypoglycemia, allergic reaction or organ damage. So how to remember this sequence? So always code in this order. 090A.2 for pregnancy affected, substance problem code to determine the poisoning or toxic effect, and the resulting condition is what happened because of it. So this is how you code this sequence. Okay. So what each term means clearly? Poisoning is nothing but too much of a drug or chemical. Adverse effect is the correct dose of medicine taken, but there is an unexpected harmful reaction. So toxic effect is nothing but harm from the non-medicines, that is toxins, chemicals, fumes or plants, etc. And underdosing is a patient takes less medicine than required, which leads to worsening disease. So this is about how you code the poisoning, toxic effects and adverse effects in a pregnant patient. So this is for today's session. I hope this session has helped you. So in the next session, you will be going to learn the continuation of this pregnancy code diseases. Thank you.